Hello everyone, my name's Eileen Regan. I'm the CCO at Examen, and it's my pleasure to welcome you to the second webinar in our 2022 Male Fertility series. As many of you know, the webinars take place on a monthly basis, and we're joined by an expert in their field of fertility treatment or therapies. The event is free and open to everyone, and we have a wide range of participants joining from academics, healthcare professionals, fertility wellness specialists, as well as the many men, couples or individuals on their own fertility journey. The views presented in these webinars are the views of our speakers and not necessarily of a company Examen. You're all very welcome to join us today, and please let me introduce you to our speakers. So this month we're delighted to have join us Dr. Mary Samplaski. Dr. Samplaski is the Director of Male Infertility, Andrology and Microsurgery at the University of Southern California. She completed medical school at the George Washington University, her urology residency at the Cleveland Clinic Foundation, and fellowship in male infertility and andrology at the University of Toronto. She has also completed additional specialty training in spinal cord injury related fertility at the Miami Project. Dr. Samplaski has received numerous accolades for her academic accomplishments, including the prestigious Bruce Hubbard Stewart Award for the Humanistic Medicine. She is committed to educational excellence and advancing the field of male fertility through her research and has over 70 peer-reviewed publications and book chapters. Her research interests include ethics, trainee education, and the role of the internet in patient care. Dr. Samplaski established and built the Male Infertility section at the University of Southern California, and it has been her pleasure to see this program flourish as it meets a critical need in the Los Angeles area. Our chair tonight is Professor Sheena Lewis, who is the founder and CEO of Examen and an honorary professor at Queen's University in Belfast, where for the past 25 years, she has dedicated her research into novel tests for male infertility. Professor Lewis is currently an executive member of the Association of Reproductive and Clinical Scientists and chair of its Scientific Advisory Committee. She has published over 100 full papers as well as numerous book chapters and reviews. She has been past chair of the British Andrology Society, UK National Representative and chair of the Andrology Special Interest Group of ESHRA, executive member of the British Fertility Society, and was a founder member and vice chair of the Irish Fertility Society. Professor Lewis's research has led to the formation of the company Examen, where we market our exact range of male fertility tests powered by the sperm comma technology, which is now the market leader for sperm DNA damage testing in the UK and Ireland. So before I hand over to Professor Lewis to introduce the session, I'll just run you through some housekeeping. So please do pose any questions throughout the talks using the Q&A panel. We'd ask you not to use the chat function for your questions, but please use the question and answer panel. And that also allows everyone the opportunity to rate questions. And Professor Lewis will then share those questions during the Q&A sessions for you. If you experience any technical issues, please use the chat function and we'll do our very best to help you. Sometimes it's out of our control, but we'll try our best. And just to let you know, attendees will be muted throughout, videos enabled for our speakers only. So all the events in the series are recorded and made available on the events page of the examenlab.com website following each session, so you can watch any events you may have missed in the series. And give us a day, 24 hours for the recordings to be uploaded and available. Also, we'll circulate certificates for those of you who have requested them for 1 CPD point after the event as well. And finally, at the end, we'll invite you for some feedback. So your suggestions and your feedback are always extremely welcome. So please let me hand over now to Professor Sheena Lewis to start the session.
Good evening, everyone. I'm delighted that you've taken time out to talk to us. This is the 1st of March and the first day of spring. And I must say here in Belfast, it's been an absolutely beautiful day. The daffodils are blooming. And when I was coming back into work this evening, there were lots of people in pavement cafes eating their first ice cream of the season. So things are good, at least in this part of the world. So this evening, we're going to be talking about drugs in the widest form and sperm. And yes, we are. I just wanted to start, as I usually do, for the new people who are with us this evening, to tell you a little bit about our company. So our mission and our purpose has been to raise awareness of male infertility, because as you know, it's been very much a hidden topic for far too long. And because we're a scale-up company from a university, we want to provide men with knowledge and advanced testing, and also to demonstrate to them that it really is worth their while to try and improve their sperm health before they go for treatment, because this is something that we really can do, and it's something that empowers men and lets them take control of their lives in a way that they haven't been able to previously. We have a big purpose, and that's to help 1 million men on their fertility journey. And we're aiming to do that, and we're expanding day by day. And we really want to work alongside patients and clients to help them to achieve their aspirations. Semen analysis is, of course, very important. It's the WHO first and gold standard, and it will tell you how many sperm you've got, can they swim, and are they a good structure. But there are other things that you really need to know as well, because it's actually the quality of the DNA which will make the child look and act like their dad. So that's really important, and we would recommend that couples take both of those tests. In Examen, as you know, we've been around since 2010, when we set up the company, due to public demand from a couple of papers that we had published that Reuters picked up. And on either side of the pond, there was a great interest in what we were doing. And over the years, we have collected CE marks and ISO accreditation. We've expanded our lab, we've rebranded, and now we've got our ISO 13485, which is a pretty difficult standard to achieve, but it just shows all of our clients the quality of our service. All of the exact tests are based on research, and they're not based on commercial research. They're based on research which I had the privilege of leading a team in Queen's University for many years. So there has been no bias in what we have published, because we had no aspiration at all when we were publishing these papers to setting up a company. That came a little bit later. Why would you use our tests? Well, because they can diagnose male infertility more accurately than the semen analysis. They can predict the likelihood of different types of fertility treatment succeeding. They're based on 25 years of fairly solid research from a large group of people. And because we provide excellent customer service, we were having one of our management review meetings the other day, and we were all feeling rather chuffed when we saw the lovely things that people were saying about us. Not that we were complacent in any way, we're always trying to make things better for you. The common test is the only test on the market that actually reports the DNA damage per sperm. And so that means that we're able to tell you how many good quality sperm you have, how many poor quality sperm you have, and the average quality of the sperm right across the sample. We've now got to the stage where 80% of the leading UK clinics in the private sector are using us. We like to make that 100%. And our goal is to move outside the UK in the very near future. So what can exact testing do for men? Well, it allows them to take back control of this situation from which they have felt really emasculated and neglected. It allows them to be equal. And I always talk about couple care rather than the female-focused care which we have at the moment. It gives them a chance to improve their sperm quality, sometimes with quite simple lifestyle changes, and sometimes by a trip to see a urologist who knows all about male reproductive health. And it helps them to engage and stay engaged in their treatment. And that's a very important factor for their partners, because quite often it's the man who said, no, I've had enough. We've had a lack of success and I'm just giving up and we're not doing it anymore. So this helps both partners to stay engaged. We're absolutely delighted to see that over the last couple of years, there's been a huge change in how the learned societies have viewed sperm DNA testing, and saying that it really has a part to play in the workups for couples who have unexplained infertility and those who have early pregnancy loss. And also the guidelines are now saying, and I know this will be music to the ears of Dr. Samplaski, that men ought to be going to see a specialist in male reproductive care, not a specialist in the female side of things. This is just a little bit more. We have so many things to talk about in terms of the learned societies, but here's the last one I wanted to show you, and this is from the WHO, and of course the WHO is the international gold standard for all of us. And in the latest manual, which they published last year, they have said that there is a growing awareness now among the experts that chromosomal anomalies and gene mutations underline a diverse spectrum of male infertility. And so they are suggesting that in many cases, an extended examination, including sperm DNA quality, ought to be undertaken. Now, this evening, we are going to devote a little bit of time to talking about drugs. And I'm sure you're all coming to this as I did a few years ago, saying, yeah, we know about recreational drugs, bad news, naughty boys. Cannabis, not good. Ecstasy, not good. Cocaine, not good. We shouldn't be taking any of those in our spare time. But surely there's nothing wrong with prescription medicines. Surely there's nothing wrong with the medication which we have been prescribed by our family doctors. Well, sad to say, there's a realization now that that is not always the case. And Dr. Samplaski, who's going to be talking to us now, published a very important review article in Nature Reviews, which is a top journal, talking about the adverse effects of common medications on male fertility. Now, one of the other things I just want you to take on board before we hand over to Dr. Samplaski is the older we get, the more pills we take. When we're young, we're probably not on any medication, but when we get into even our mid-30s, we start having chronic illnesses of some sort. And the later we leave it to have our children, then the more likely it is that we will be taking other medications. And of course, this means that this is a factor which in these days we have to take into consideration when probably our grandparents, when they had their children in their late teens and 20s, didn't have any concern about at all. So tonight we have Dr. Mary Samplaski. Eileen has told you all about her credentials. I absolutely love this shot, which had just a picture of her saying, why male fertility is important. And I can tell you, she and I sing from the same hymn sheet. She's a pioneer woman in urology. There aren't many specialties left which are dominated by men. Alas, urology has been one of them, but there are a few outstanding women, of which Mary is one, and they have devoted their careers to looking at male reproduction and to raise the banner that we need to look at men and their needs just as well as we look at women. So I'm going to hand over now to Mary. I can't wait to hear what she's going to say to us, and I hope you'll all enjoy the talk and we'll chat. Send any questions you have and we'll chat about them later. Thank you.
All right. Can everyone hear me? Okay. So I'd like to thank Dr. Lewis and the whole Examen team for having me. Certainly, I echo Dr. Lewis's sentiments that having the male play a larger role in the conception of these babies is sort of something that needs to be sort of a call to action. So many of the female fertility clinics are very female centric, and the guys often end up feeling like they are just sort of a sperm donor. And I don't think that's what most men want. And often there are so many things that we can do to improve sperm quality so that couples can either achieve natural pregnancies, which is I think what most of our couples want, or if they're going to go down the route of assisted reproductive technologies, give them the best sperm so that they can achieve a pregnancy with the least invasive method and with the least number of miscarriages. So I do think this sort of call to action to sort of have the male factor get a little bit more scrutiny is ultimately going to benefit our couples. So what we're going to be speaking about tonight is the effect of medications and non-medications, sort of recreational drugs on male infertility. These are my disclosures. None of them apply to tonight's presentation. So by way of overview, We're going to talk a little bit about medication use in males of reproductive age. How many medications do you guys use, and what does that sort of prescription timeline look like? And what reproductive testing, at least in the US, is required before a drug reaches market. And then the many ways that medications and non-medication drugs can affect fertility, because it's not as simple as just sort of sperm counts. And first, we're going to talk about the prescription medications, and then we'll shift gears to the non-prescription substances. So we know that the adverse effects of medication on male reproduction are often inadequately recognized, and this can prevent couples from achieving their reproductive goals or using assisted reproductive technologies that they might not need. Men produce sperm from the time of puberty until death, and guys are having kids later into life. So it's so important for physicians, nurses, anybody who's involved in their care, even spouses, to ask about the medications that they're using, and sort of raise those questions. Can those be affecting their reproductive capacity? So this is data from the National Survey of Family Growth, which is in the US a sort of subset of the Centers for Disease Control, showing when are guys having kids. And we know that most men in the US father 2 children. 74% of these are before they're 40 years old, but 25% of guys will have kids after 40 years of age. And so we know that there's definitely been a shift in parenting patterns where guys are having kids at older ages in life. And so with that goes more medication use, more substance use, and just sort of more life exposures. And so it's important to sort of not forget to ask. And sort of to Dr. Lewis's point, with age, people take more medications, men take more medications. So the bar chart on the left side of the screen is prescription medications or non-prescription medications. And the bar chart on the right is prescription drugs. And so any medications, which would include things like ibuprofen, acetaminophen, over-the-counter proton pump inhibitors, and sort of things for sleep. So you can see that with age, the number of prescriptions increases, both prescription and non-prescription. And in guys who are 18 to 44 years, this goes from 68% of men using a non-prescription medication to up to 30% of guys using a prescription medication. And we know that guys are having kids later into life. So if you think of 65 as sort of a loose upper limit for when guys are having kids, 81% of those guys are using some type of medications, and up to 50% of those are prescription medications. So I think it's so important for any kind of provider or anybody who's involved in the reproductive care of these guys to just sort of ask, to just sort of put it out there. What are you taking? Because this could affect their reproductive capacity. And I think this is quite alarming when you sort of actually know what kind of testing is required before a drug reaches market. And again, these are more of the prescription drugs. The Food and Drug Administration says that animal studies should include some type of male reproductive toxicity testing, but that's super vague. And the requirements for human clinical trials are very vague and oftentimes non-existent. So I think it's important to realize that just because a medication affects sperm production or sperm parameters in a petri dish, does that mean that it affects it when a man takes the pill by mouth? Is a petri dish the same as a human? I don't think it's the same. Same thing with animal trials. Spermatogenesis is different in monkeys versus rats versus humans. Rats and mice both have intra-abdominal testicles, and have scrotal testicles. And so the whole sort of model is different. And so just because things affect, just because medications may affect sperm production in animals, we don't necessarily know what they do in humans. It's not sort of an equal comparison. Some drug effects are only realized once medication reaches result or reaches market. And then we also just don't know what those medications do to the offspring. So sometimes you don't know about teratogenesis or translational effects that can be seen. And so I just think, while some testing is required, not that much testing is required. And sometimes the testing does not necessarily reflect what might be seen in an actual human taking a medication. So medications can affect male fertility in a variety of ways. So the sort of one of the main ones is obviously sperm production. So the number of sperm, how the sperm swim, their shape under the microscope, their DNA breakage, but then also the signals that signal sperm production. So the hypothalamic pituitary gonadal axis. So what about medications that affect the signals that tell sperm to be produced? And then what about medications that just affect sexual performance? Certainly, if a guy is having difficulty achieving an erection or has no interest in sex, they're going to have trouble achieving a pregnancy. And then also the teratogenic effects that can affect offspring. So the first one we'll start with is testosterone. This is a huge worldwide market that has just exploded in the last 10 years. The number of prescriptions that are written has increased by 90% in the last 10 years. The usage has increased, I even bet it's more than threefold. And this is largely due to direct-to-consumer marketing, but also a sort of growing awareness by clinicians of the benefits and risks of testosterone, sort of making it less of a taboo medication for patients to be on. So this is data from a JAMA paper looking at trends in prescription writing between 2001 and 2011. There has not been an updated paper looking at the same thing. But what you can see is all of those bars are different routes of testosterone administration. So the red line is the gels, the green line is shots, the second blue line is, sorry, the light went out. The second blue line is patches, and then the top blue line is the overall. And you can see, particularly since 2008, the number of testosterone prescriptions has gone up. And within the sort of meat of the paper, 12% of these guys who started testosterone replacement were between 18 and 39, so right smack dab in their reproductive years. And 74% of these were between 40 and 64. So testosterone, I think the point is being written to a lot of guys who are reproductive age. And testosterone in a nugget, testosterone will impair sperm production. So how I explain it to patients is that when you give somebody testosterone, the body stops making its own. So testicle sort of inherently stops making as much of its own testosterone. The signals from the pituitary to the testicle and from the hypothalamus, so GnRH, FSH, and LH, all decrease. So the signals to the testicle saying, make your own testosterone, make your own sperm, decrease. So testicle sort of goes into like a state of hibernation where it stops making its own testosterone and its own sperm. And testicle usually has testosterone levels that are 50 to 100-fold higher than the peripheral blood. So without testosterone in the testicle, the whole sort of sperm production factory slows down, to the point of where there's plenty of trials looking at exogenous testosterone as a male hormone contraception. So, I mean, this effect is real, and this works. So the largest and longest study looking at sperm recovery after exogenous testosterone, because the question for some men will be, okay, if I go on exogenous testosterone, okay, my sperm counts will lower, but will they come back? And this is the largest and longest study looking at sperm recovery. They took 1,045 eugonadal men, all of whom had fathered a child within the last year, so all of whom were proven fertile. They put them on exogenous testosterone, and on the y-axis of this graph is sperm concentration. And so you can see the sperm concentration decreases, decreases, decreases. And 95% of these guys were either azospermic or severe oligo, so less than 1 million sperm. So, I mean, this works in terms of its lowering of sperm count effect. When they took the guys off in the recovery phase, sperm counts recovered. So almost everybody recovered, 99% of guys. Only 2 guys did not recover their sperm production. But, in the minds of a clinician, these two guys, it's sort of like, why did they not recover? And so what I tell patients is almost everybody recovers their sperm counts, but I can't promise you that you're not going to be those outliers. And so it's definitely just a discussion to have with the patients, but almost everybody will recover, but it's not 100%. So first group of medications, 5-alpha reductase inhibitors. These have two primary sort of usages in the world. First is at a higher dose for BPH. Second is for male pattern baldness or androgenic alopecia. And what these do is that they block the conversion of testosterone to the more potent androgen of dihydrotestosterone. There's two main drug medications, finasteride and dutasteride. Finasteride inhibits type 2 isoenzyme. Dutasteride inhibits both type 1 and type 2. And they change the testosterone to dihydrotestosterone ratio by different amounts. So what do they do to sperm? So both of these medications will result in a lowering of sperm counts. It's definitely statistically significant. It's not by any means as profound as exogenous testosterone. So about 25 to 30% lowering of sperm counts, and it's recoverable. So for most guys, these medications will hurt their sperm to some degree, but for some people, that 20 to 30%, they can still achieve pregnancies with. But it's definitely something to sort of be aware of as providers and as people want to help our men have babies. But this is a study I did in my fellowship, actually, looking at guys presenting for fertility evaluation. So these are guys, it's a different population. These are guys who are seeking a fertility evaluation, saying we haven't gotten where we want to be naturally. And these guys were taking 1 milligram of finasteride, so androgenic alopecia dose. And what we found is that when you took the guys off of their finasteride, their sperm count went from 32 million to 127 million. And so it's an 11-fold increase. So it does seem that for some people, even low dose finasteride, even 1 milligram a day, just such a little small dose, throwing off that testosterone to dihydrotestosterone ratio will severely impact their fertility potential. So in my mind, anybody who's trying to have a baby, it's worth a discussion about them coming off those medications. The other thing that patients are aware of is this concept of post-finasteride syndrome, where finasteride can cause erectile dysfunction, diminished sexual desire, ejaculatory dysfunction. And there is some data showing that there is a particular sort of CSF neurosteroid phenotype to sort of predict who these individuals are. But obviously not all of our patients are going to undergo a lumbar puncture before they start these medications. But it does seem to be, in my opinion, a very sort of real effect for some patients. This is data from the PLES trial. 3,000 men with BPH who were managed with finasteride versus placebo. And these medications work very well for BPH, but sexual side effects were the most commonly reported side effects seen in about 15% of guys. And I think what's worrisome to patients, and patients are definitely scared about this, is that sometimes even after you stop the medication, the sexual side effects persist. So mean duration of sexual side effect persistence was 40 months. So almost 4 years after stopping the medication is how long it took for some of these guys to recover. And some of them lasted over 6 years. So I think, it's definitely something to sort of have on the radar, that these medications can both hurt sperm production, but can also cause sexual dysfunction, which can be really, really troubling for the patients. Shifting gears to the alpha blockers. These are also used for prostate enlargement. Largely, these will affect sexual performance by causing ejaculatory dysfunction, so either anejaculation or a variable degree of retrograde ejaculation or failure of seminal emission. And this is just data showing the degree of decline in ejaculate volume. So this was a randomized 3-way crossover trial of tamsulosin, alfuzosin, and placebo. And you can see that tamsulosin caused a impairment in ejaculatory volume of 2.4 cc's. And 35% of guys taking tamsulosin had complete anejaculation. So tamsulosin, I think this is an effect that many of us have seen as providers, will affect ejaculation, not in everybody, but I estimate about 70% of guys. And the odds ratio for ejaculatory dysfunction is super variable, but silodosin and tamsulosin have the highest ratio or highest risk of having some degree of ejaculatory dysfunction. These also can cause impaired libido and erectile dysfunction. It's a lower percentage than what's seen in the guys who are on the finasteride, but it's definitely something that can still be seen. And also, these medications can impair semen parameters. There's not a whole lot of studies. This is one of the only studies that was published since from 2009, but they did show that tamsulosin resulted in a lower sperm count, 54 million, which is a pretty big number in the world of sperm counts. Phosphodiesterase inhibitors, we always think of these as giving guys a little extra boost when they need to perform. And there are definitely studies looking at, do these medications affect fertility? And I think it's interesting because phosphodiesterase in different isoforms is expressed in sperm. So I think it makes sense. PD5 is found in the flagella. PD5 is also found in the acrosome. Phosphodiesterase 11 is found in Leydig cells. So I think it makes a whole lot of sense that these medications may or may not affect sperm function, but certainly this is an effect that we should be aware of. And basically, the available data is conflicting. There's been one study that showed improved semen parameters, one study that showed no change. Both of these were randomized controlled trials. The one that showed improved semen parameters was with sildenafil. Still sort of a marginal improvement, though, 36 million to 43 million, and then an improvement in the total sperm count. 400 men treated with tadalafil showed no difference. So in my mind, I think PDE5s are okay for guys trying to achieve a pregnancy. Psychotropic medications. This is a whole big, this could be a lecture or a discussion even in and of itself. So we're going to sort of try and keep it succinct. But I think the important parts for this is, number one, these medications are used in all age groups. They can affect sexual performance. They can throw off hormone release. They can affect ejaculation, and they may or may not affect sperm depending upon the class of medication and the studies that have been done. In terms of how they can affect hormone release, I mean, and again, I'm trying to keep this sort of succinct, but basically they can affect many different aspects that can result in impaired FSH and LH and testosterone release, which ultimately signals the testicle to make sperm and can improve sexual performance. So we use SSRIs, at least in the States, off-label for premature ejaculation. They will delay ejaculation, and they work pretty darn well. The one we use the most is paroxetine, but sometimes this works too well, and sometimes it can cause delay or anejaculation, which can be quite frustrating. And the other thing, and this is right up Dr. Lewis's alley, and this is something I ask all of my fertility patients about, is SSRIs and DNA fragmentation. So this is data from a prospective crossover study of 35 men who were given paroxetine, and these men served as their own controls. And the authors looked at semen parameters and sperm DNA fragmentation rates. And what you can see is the purple bar is baseline, the red bar is SSRI after 2 weeks, yellow bar is 4 weeks, and blue bar is 4 weeks. So you can see the sperm parameters look about the same. So guys before and after going on an SSRI. But the DNA fragmentation changes. The DNA fragmentation goes from 13% to 30%. 30% is usually our threshold for sort of intervention for DNA fragmentation. And, DNA fragmentation, for those who don't know on the webinar, this is something that's not detected on the raw semen parameters. This is the number of breaks in the sperm genetics material. And this has been associated with poor natural pregnancy rates, poor in vitro success rates, poor IUI success rates, and higher miscarriage rates. So I think so many of our patients are taking these medications. And in my mind, this is such a, these couples who have undergone failed assisted technologies, multiple miscarriages, I think this is something that I've definitely started to ask about and look for in my practice. And this does seem to be a reversible effect when the medication is discontinued. Whenever we're talking about taking guys off of these medications, it is something that I tell them to sort of do in conjunction with their mental health professionals. Certainly some of these people need these medications to sort of function. So I'm not saying just take it away, but 100% this is something that we should be asking our patients about, and at least giving them this piece of information to sort of help in their medical decision making and give them answers as to why things might not be happening on their own. Blood pressure medications is a huge topic, sort of like the psychotropics. It could be a lecture or a discussion in and of itself. So I'll try and sort of hit the high points. Beta blockers, we know that these medications can cause vasculogenic erectile dysfunction. And there's about a 1.2 relative risk of sexual dysfunction in a whole range, including impaired sexual desire, impaired sexual frequency. So in addition to just the erectile dysfunction, some of these medications can hurt sexual interest. There's very few studies, and this is looking at the effects of beta blockers on both sort of human fertility. So this is one of the only studies I could find from 2007 looking at rats, mice. And mice who were given propranolol, they had lower weights of their testicles and epididymis. They had lower number of spermatocytes. They had higher miscarriages and lower sperm density rates. This did seem to be a reversible effect, but I would take data like this with a little bit of caution, because this does not necessarily extrapolate to a human taking a therapeutic dose of a beta blocker, because the same studies really have not been done in humans. Diuretics can affect sexual function through their vasculogenic effects. I would just want to take a pause at spironolactone, because this in and of itself can reduce testosterone production and results in gynecomastia and erectile dysfunction. Sorry, the lights want to save energy. So ACE inhibitors, I think this is a particular sort of interest, because there is a testis-specific ACE, which is found in the postmeiotic germ cells. And there is a little bit of animal data showing that some mice who have ACE gene variants have sort of impaired fertility on a variety of fronts, including lower sperm vitality, higher oxidative stress, lower sperm counts. But these studies have not been done in humans. Human studies, the best that has been done is taking sperm, putting them in a dish with captopril, and showing that the captopril impaired motility. But in my mind, this is not the same as somebody taking a ACE inhibitor pill every day. So I think we just don't know the answer to this yet. Calcium channel blockers, I think, makes sense, because calcium is critical for the acrosome reaction and for capacitation. Also, there's a little bit of animal studies showing that it could, taking these medications could affect implantation and litter sizes. But in humans, no change in fertilization rates using natural pregnancy or IVF in guys taking therapeutic doses of calcium channel blockers. Antibiotics, certainly a group of medications that many of our patients take. It can be very tricky to tease out when there's negative effects, if it's from the underlying inflammation versus the antibiotic versus any anti-inflammatories that the patients are concurrently taking. So it can be very difficult to interpret these data. And I will tell you, almost all of the studies that are presented are from the 70s and 80s. There's really not a whole lot of great quality data, but I'll sort of give you my interpretation of the data. Penicillins and cephalosporins, humans don't have a bacterial cell wall. That's how these medications work. So we wouldn't expect them to affect mammalian cells based on data from the 80s. At high doses, it may, there's been a single report of high doses of Pen-G causing spermatogenic arrest in rats, but really this has not been shown to be the case in humans. Trimethoprim, we use this a lot for prostatitis and orchitis. The available data is conflicting in guys with positive semen cultures tested in two different studies, 14 days versus 30 days. Sperm counts decreased by 30% versus no change. Again, it's so hard to tease out the underlying inflammation versus the actual, the trimethoprim sulfamethoxazole. So I don't think we totally know the answer yet. Nitrofurantoin, again, these studies from 1957 and from 1975, lower doses, and this is from a study from the 80s and the 90s, at therapeutic doses, it seems to be safe. It does not seem to affect sperm counts. Macrolides, this was one of the only studies that there was actually double-blinded placebo-controlled data in humans, did not seem to affect semen parameters in guys who were baseline poor motility. When you actually cultured the sperm, like when they put the sperm in the petri dish with this antibiotic, it did seem to sort of inhibit motility. But again, it's so hard to extrapolate whether this, if it happens in a petri dish, does it happen in a human? And aminoglycosides, I do think the data, again, scant data, but the data does seem to show that these can hurt spermatogenesis to some degree, causing increased abnormal forms. Neomycin has been shown to affect sperm counts. And this is both in animals and humans. So this is a group of medications that I try and avoid. Antifungals, very, very scant data. High doses can hurt testosterone production. This is ketoconazole specifically. That's the only antifungal that there's any human data in. But we really just don't know. Okay, shifting gears in the last 15 minutes of our talk to non-medication, but certainly substances that many of our patients use. And I think some of the most common questions that come up in our fertility discussions. So we know that alcohol can affect multiple ways that can potentially affect both the global human and spermatogenesis in particular. So it can cause, it's essentially a pro-inflammatory state, high pro-inflammatory cytokines, lowered antioxidant capacity, so sort of higher pro-inflammation, lower ability to accommodate that high inflammation, can cause higher rates of DNA strand breaks and oxidized bases, and also sort of higher levels of mitochondrial damage and higher levels of apoptosis. So it just sort of sets the stage at a higher alcohol usage rates for a pro-inflammatory state. And this is one table from a great review article by Dr. Agarwal. And I think it does a very nice job of sort of lumping animal studies versus human studies and the effects of alcohol on humans and the reproductive capacity. So for hormones, seems to be a little bit mixed study. And I think particularly when we think about the substances, and this is what I tell the patients, it can be so difficult to tease out one factor from another. So teasing out how much somebody drinks or how much marijuana somebody uses from their daily occupational exposures, the amount of radiation that they're exposed to in life. Certainly pilots are exposed to more radiation because of the nature of their job. People who work in an oil field, they're going to be exposed to a lot of environmental things? What about the role of diet? What about all the things that we put in our body? What about the role of antioxidant supplements? And so I think that is why it can be sometimes so difficult to tease out the individual contribution of, let's say, alcohol and how much alcohol is okay. But nonetheless, we sort of do the best with the data we have and try and guide our patients down the right sort of path to help them achieve their reproductive goals. And certainly there is some evidence that shows that higher alcohol intake can affect all semen parameters: volume, count, motility, morphology, DNA fragmentation. And there also is some transgenerational evidence showing that it can affect the offspring, that higher levels of alcohol use in the dad can cause congenital heart defects, cancers in the offspring, and reproductive issues in the offspring. So I think it is sort of, it should 100% be a part of any fertility discussion. So what is a safe amount of alcohol for the patients? Because the patients ask this. This was a Danish study, 1,200 men, all reproductive age, undergoing essentially a military history and physical. The patients were asked about how much alcohol they consume. And then they had a semen analysis. So what they found was that with increasing, particularly habitual, so they didn't just say for the last week how much alcohol did they drink. I think they asked for over the last 3 months, which I think is sort of important because sperm production takes 72 days. So the final sperm product really is the reflection of the sperm or the testicular environment for the last 3 months. And so with more habitual drinking, there was a lower sperm counts and lower sperm morphologies. And you saw this most in guys who were consuming more than 5 drinks per week. Guys who were really heavy drinkers, more than 25 or more than 40%, 40 drinks per week. Guys who had more than 40 per week had a 33% reduction in sperm concentration versus guys drinking 1 to 5. So I think from studies like this, you know, every provider is probably a little bit different. I tell patients if they, you know, if having a glass of wine with their spouse at dinner is a part of their life, I think I tell people to try and keep it to less than 3 per week. And I think that's sort of reasonable based on the available data. Moderation is key. So shifting gears to marijuana. So we know that marijuana's active metabolite, teratohydrocannabinoid, can alter signaling pathways within spermatozoa and affect spermatogenesis and fertility. And these are all the different places in the body that cannabinoid receptors are found, but they are found on the reproductive system. And, you know, I don't know what the sort of environment is within the UK, but marijuana has more and more states within the US are legalizing marijuana. This is something that patients are so much more honest and forthcoming about in how much they use and the types that they use. And so I think it's something that as a medical community, we really need to understand better so that we can sort of counsel our patients. Going back to the same pool of data from the Danish pool, but they published under a different, it was a different study. And they asked the guys how much marijuana that they used. And they asked guys if it was for the last 3 months, if it was none, 1 time per week or less, or more than 1 time per week. And guys who used it more than 1 time per week had 20% lower sperm concentration. So guys who used more than 1 per week plus other drugs had a sort of a exponential effect, 50% lower sperm concentration. So, you know, based on sort of data like this, I tell people I think 1 time a week is too much. And I think if you're really trying to set guys up for success, I tell people if you can try and quit, that's sort of what I think is the best thing. But if they need it for sort of life and for functioning, then if they can, less than 1 a week. This is data. It's also retrospective. So it's also a patient questionnaire from the University of Seattle, very, very recent, just published in 2021 in July. Also asking guys about their history of marijuana use. And they lumped these guys into moderate, which was 1 to 2 times per week, or not at all, or frequent, which is more than twice per week. And actually what they found was less related to the counts, less related to the motility, and more related to the sperm morphology. So how do the sperm look under the microscope in terms of their head, their neck, and their tail? And guys who used currently or in the past were more likely to have abnormal morphology. Interestingly, the marijuana was protected from motility. You know, I'm not sure if I necessarily believe that it's going to improve sperm motility, but I think the take-home point is that it did seem to correlate with the sperm morphology. And even at sort of what many people would consider a lower use rate of once a week. And this is a Jamaican study, much higher reported rates of marijuana usage. And guys who used larger quantities of marijuana had poor motility, also poor morphology. But the other thing that this study found, and I do think I see this in clinic, although it's never been quantified to the degree that this study did it, was they found that guys who used higher doses of or higher rates of marijuana had a change in how their testicles feel. I personally have seen guys who say that their testicles feel softer when they use marijuana more frequently. Testicle shrinking. There is definitely data showing that chronic marijuana use can alter FSH and LH release. Higher rate of finding testicular masses, higher rates of erectile dysfunction, higher rates of gynecomastia, higher rates of infertility. So I think, you know, and these are all patient reported. It's a little bit more sort of recall bias, but I would say these are things that I've seen in my clinical experience as well. Oh, sorry, I thought we got 7 more minutes. So caffeine is something that patients ask about also. You know, there are hundreds of studies trying to sort out the impact of caffeine use, and our different types of caffeine. Is a caffeine coffee the same in terms of its safety or not safety as respect to a cola drink as compared to a caffeine tablet? And there are some labs that will use caffeine to sort of stimulate sperm motility. And I think this was a great review article that I found. And what they essentially found was that the raw semen parameters seem to be sort of not affected as much by recreational caffeine use. They actually did see a difference with respect to coffee versus colas, but the DNA fragmentation seems to be affected by caffeine. So I think that's sort of something that would not be detected on routine semen parameters. And they can also be associated with prolonged time to pregnancy. All right, wrapping it up. So in conclusion, we know that more men are taking medications. The number of people who take medications is increasing. People are having kids later into life. For many medications, we just don't know. Like, just because the absence of data does not mean that it does not hurt fertility. And also just the raw semen parameters do not tell the entire story in terms of how a drug can affect a man's fertility potential. But the things based on sort of my research, what I've seen, what I've read, to avoid 5-alpha reductase inhibitors and alpha blockers, SSRIs, and aminoglycosides. And for most substances, I think moderation is key. If possible, stop completely the marijuana. If they need the marijuana, less than once a week. Caffeine, I tell guys 1 cup a day or less. That is, again, I tell people if they can cut back, but you sort of, I don't want to take away every joy for these guys. And I think marijuana is probably worse than caffeine, and alcohol, 3 drinks a week or less. But, these are all moving targets. If you ask me in 5 years, I may have more or less restrictions. But again, thank you, Dr. Lewis. Thank you for having me speak. This is my wonderful team in Los Angeles. It's springtime here, but our springtime was 85 degrees yesterday, which is like unseasonably warm. And then today it's down to 60 degrees. So hope this has been helpful. I'd be happy to entertain any questions. And again, thank you for inviting me.
Thank you so much. That was really interesting. If you had another hour, I could fill it by asking you questions all by myself, but I know I'm not allowed to hog the floor. I did want to ask you one thing about sildenafil, because you very kindly cited one of our papers there. And one of the things that we found about sildenafil was that the sperm were flying along. I mean, they really were going like crazy, but they got burnout. So that you could even get guys who'd poor motility, you could bring them up to normal motility, but it only lasted for a while and then they just died. And the same was true with acrosome reactions. They had their acrosome reactions prematurely. So presumably by the time they got to the egg, there was no acrosome left. So we were quite concerned about it being, a real block to fertility.
That's very interesting because, obviously what you have seen is, what you've seen like with your sort of firsthand eyes is so much different than like reading these papers in a sort of retrospective way. And so honestly, that's a great lesson for me because in my mind, these medications were pretty benign, but maybe not.
Yeah, and caffeine, of course, is a non-selective PDE inhibitor as well. So it's exactly the same. It's the same group of medications as Viagra. So again, caffeine has that effect, and I've seen papers on this. It really makes the sperm go, but then they lose energy. And funnily enough, we also did quite a number of studies about 10 years ago on cannabis, and cannabis was the opposite. And when we looked at animal studies, the male animals were so laid back they just wouldn't even mount the females, and they didn't mate. So we thought if we could get this cocktail of Viagra and a little bit of tea. I'm only joking. But anyway, let's go to our first question. Now, this is not something really that you've said very much about, but I wonder if you could answer a question on the effect of statins and cholesterol tablets on sperm.
That's actually a very good point. Yeah, there was recent, I believe it was 2 or 3 years ago, there was an abstract, I don't remember if it was published, that showed the problem was it was a population-based study. And so they had taken guys who got a statin prescription and looked at semen parameters and compared guys who had gotten a prescription to those who had not. And there was impaired sperm motility. And so I know that actually did get some press. To my knowledge, what has not been done is taking a guy, checking a semen parameter, putting him on a statin for 3 months and checking a semen parameter and seeing or checking a semen analysis and seeing if anything changes. But yeah, there is, like I said, at least the one population-based study showing that it may impair sperm motility.
Mm-hmm. Yeah, I think one of the huge limitations of all of the studies that we're talking about here is they're based on semen parameters. And as we know from the WHO manual, you can look at the same man over and over again and his semen changes so much. So if you look at a semen on day 1 and you look at a semen on day 60, it could change hugely. I mean, that's standard, that's normal. So how can you really see what the effects of a particular intervention are on that?
Yep. And that's not even taking into account the DNA. Like
Yeah. I know.
It's just like even some of these studies that show like a difference of like 15 million. It's sort of like, is that just normal daily variation, or is that a real difference?
Sure. Here's another question for you, and this is about Nexium and omeprazole. Do you know if they have any effect on male fertility?
Oh man, I honestly don't. I don't recall. I would have to. I would be lying if I would have to do a little PubMed search, but I'm happy to do that and sort of.
Yeah,
go back.
Well, let's go back to another one, and that's alcohol, because we're very often not inclined to think of alcohol as being a drug, and of course, it's the most commonly consumed drug of all. You're being very, very rough on the men that they're only allowed 3 drinks a week, I think. But, yeah.
Well, I mean, and I don't know, we all come at this with our own experience, right? But I've had so many guys come to me and they have had, and this is my experience, but they're not allowed to ride their bicycle. They're not allowed to like hang out with their friends, because what if one of the friends has a cigarette? This is independent of COVID, but no drinking, no coffee, no marijuana. And like, there's a lot of no's that enter the sort of discussions. And so, you know,
loads of sex, that's the one thing their partners do a lot.
Yeah. And like a lot of them go to these like female fertility clinics where they're told no drinking. And so for me to say, I think it's okay for you to have like 3 drinks per week, it's like giving them back something. And is it, to be honest, I think probably 5 is okay, but like, you know, walking that fine line of keeping everybody happy and sort of, but giving them something. But there's so many people who tell them like 0, no alcohol, no caffeine, no masturbating, no nothing, lots of no's.
Yeah, I don't think people can sustain that. I think that's the problem. So I like the little picture you had of everything in moderation. It depends what moderation is. Moderation is very different to different people. But I agree with you entirely that if the fertility journey is a long one, and it very often can be, then we've got to allow some let out for men who are otherwise going to feel extremely stressed. And we don't even know the effects of stress on fertility, but it's not going to do their relationships with their partners any good either.
I worry that too, that like sometimes the stress effect of all of the things that are being taken away from them, if that offsets the good to some degree. And that's why I sort of try and like let them ride their bikes. I don't know, you know, do what makes you happy. If you can, you know, cut out the marijuana, that'd be amazing.
Absolutely. We have another question here, and it's saying, you know, the DNA seems to be, you know, one of the very good biomarkers, and of course I would buy into that. But it's also asking, is there anything else, you know, if we put the semen parameters aside for now, and we have to because they're so variable, is there any other sort of promising tool that's coming up on the horizon that we can think of?
There's one other test that I use periodically called and I don't know if this is sort of, you know, marketing another, but it's called the CAP score. And it basically measures, and, you know, I don't use it that often, but it is interesting to have another tool in our toolbox, because we really don't have
enough.
No.
I agree.
Yeah. So the CAP score is looking at the ability of a sperm to sort of bore through the egg and undergo the acrosome reaction.
Yeah, and that of course is so important. It's important in IVF as well as with natural conception. I'm just having a look to see if there are any further questions, because I know we've kept you for quite a long time, so I'm just wondering if we can finish with the last question. Anti-epileptic drugs. Do you know anything about those, and particularly their effects on DNA?
Yeah, so most of them are very poorly studied. That's why I sort of glazed over. A lot of them will sort of definitely throw off prolactin binding, which can then cause, you know, changes in testosterone bioavailability. So a lot of them can like throw off the hormones, but the effects of them on semen parameters are very, very, very poorly studied. Like anything that there was human sort of prospective randomized control trial, I tried to include. And so I just don't think they've been very well studied. It's the very short answer. I don't think we know. Yeah. No, I think you're right. And I'm absolutely delighted that you've come and shared your knowledge with us this evening and pulled it all together for us, because it's a huge area, but it's one that's very fragmented at the moment. And there are so many poor studies, and it's very hard for the onlooker to, you know, to get a grasp of it. So we really appreciate your time. We really appreciate you putting together that talk for us. I see we've got, you know, about 40 people who are listening to it. There'll be many more who will listen once it goes onto our website. So I can only thank you again very, very much. And I hope I'll see you soon in person. So we'll hand back to Eileen. Me too.
Oh, apologies. Thank you for joining us, everyone. And just to give you a brief overview of the next events in this series. So unfortunately, we have business commitments in April, so we won't be here, but don't worry, we'll be back in May. And absolutely delighted to welcome Dr. Dori Lamb on Tuesday, the 3rd of May. So Dr. Lamb is an investigator in the fields of urology, male infertility, steroid hormone action, prostate cancer, and genitourinary birth defects. And she is joining Examen to discuss how male fertility has changed in recent years. And then on June 7th, we'll be joined by Professor Christopher Barrett, a global leader in male fertility, who was appointed to the editorial board of the World Health Organization for the development of a new semen analysis manual that Sheena touched on earlier. And he recently published the global WHO guidelines for semen analysis reference ranges. And he will be discussing why a global approach is needed to address the policy, research, and social challenges of male reproductive health. So if you haven't already registered for the events, you can do so via our events page on theexamenlab.com/events. So that just leaves me to say thank you again for joining. Don't hesitate to reach out if we can help you in any way. Thank you very much to Dr. Samplaski for joining us this morning. Early morning for her and an evening for us here in the UK. So thank you, everyone, and we look forward to seeing you at our next webinar on May 7th. Thanks and enjoy the rest of your day.
Bye.